Welcome to another episode of the Bleeding Edge of Digital Health. We're really excited about today's guest. We've got the co-founders from Rely Health. We've got Soham More, who is CEO, and we've got Prithvi Narasimhan. How are you guys doing today?
Doing well. Thank you so much for having us, Mike. We appreciate the time.
Yeah. No, I was excited to film the episode for sure. So you guys have built a really exciting conversational AI technology. Um, why don't you tell me a little bit more about it? Just a brief synopsis of it.
Absolutely. So we're Rely Health, and today we're really diving deep into a problem that healthcare organizations face nationwide, the labor shortage. And this is particularly impactful for what we consider lower wage roles, particularly those that are care navigators, coordinators, discharge specialists, front desk, receptionists. Really, the nomenclature varies, but across the country, organizations are facing a shortage of these types of roles. And one of the biggest concerns of that is how does it impact patients? So our goal as a company is to really help organizations fix this issue. And one of the ways we do so is by leveraging artificial intelligence to step in and bridge the gap we have with FTEs and not enough people to service this need.
So I think it'd be really great for the audience to hear a little bit about the technology and how it works in a second. But if we can, I just want to play a clip of this because I don't think people can really get a feel for exactly how powerful this technology is unless you really hear it. So, Lily, can you run the clip real quick?
Hi, you've reached the after hours call line for Arrowhead Regional Medical Center. My name is Pam. I am an AI answering service to get your message. To start, can I get your full name and which clinic you visited?
Yes, my full name is Sam Smith, and I think it was the clinic on Baseline Avenue.
Thank you, Sam Smith. That would be the Arrowhead Family Health Center, Fontana. Could I also have you verify your date of birth and the best callback number?
Sure, July 5th and 408-893-1234.
Thank you for providing that information. I'll need your full date of birth, including the year, to proceed. Could you please confirm that for me?
Sorry, July 25th, 1997.
Thank you for clarifying. I have your date of birth as July 25th, 1997. Now, how can I assist you today?
I got this side effect from a medication I was prescribed during my visit. It's a rash.
Thank you for letting me know, Sam. Can you provide more details about your rash? For non-serious issues like this, I can redirect you to the IEHP nurse hotline for immediate assistance. Would you like to be redirected?
No.
Understood, Sam. Can you describe the rash for me? For example, where is it located and when did it first appear?
Red, flaky on my back, and it first appeared when I started taking the meds.
Thank you for that information, Sam. Could you also let me know the name of the medication you were prescribed and the dosage you've been taking?
Yeah, it was levofloxacin, 750 milligrams daily.
Thank you for sharing your information, Sam. We've recorded your request, including the notes and history you've provided. Please note that this after-hours phone line does not offer medical advice. Our Arrowhead nursing team will get back to you within one business day. If your issues worsen or become severe, please visit your nearest emergency department. Thank you.
I have shortness of breath.
Sam, shortness of breath can be a serious concern. This phone line is not equipped to handle emergencies. Please dial 911 immediately or visit your nearest emergency room. Thank you and take care.
Yeah, that technology is pretty unbelievable. The first time I heard it, I couldn't believe that it was actually computer generated. It's so authentic and so real. The technology is amazing. Can you tell the audience a little bit about the use case? What's the problem? Why does the technology exist? Why did you guys create the technology?
Yeah, so I mean, care navigators and patient coordinators and social workers today are overburdened and don't have enough time to see every patient that they come across. At your typical ED, you have thousands of patients, tens of thousands of patients coming in per year, and the case management team just can't reach out to every patient that needs their help, and can't build those deeper engagements. And that's where we really come in with AI. where these roles are incredibly empathetic. These are folks that really care about the patient and getting the patient to the right place. But unfortunately, the status quo today is that they spend 80% of the day doing stuff that can be easily automated. Like, for example, copying and pasting data from the EMR, making phone calls to patients who might not need their help but just need a quick check-in, leaving voicemails, uploading data from one system to another, sending faxes, calling up providers and making appointments. That all takes so much of time. And at the crux of it, this job is really focused on the patient and making sure that patients hear that empathetic person on the other end of the line and get the follow-up they need. And that's what AI enables us to do, taking away all of that grunt work. And instead of having that 90% of the day be grunt work, make it 100% of the day being those empathetic conversations with patients, building relationships, rapport, and getting patients to where they need to be.
Yeah. Yeah. I read a McKinsey study that I think $150 billion is wasted every year just in no-show appointments alone, which blew my mind. So that tells you right there that there's incredible gains to be made in the market. How is this managed right now? Is obviously it's human capital right now, but what's the existing structure that you guys are potentially going to replace here?
Great question. So for us, AI is a force multiplier, but fundamentally what we do for health systems is we provide them trained navigators, social workers, and case managers to help meet their demand. If we look at the bigger picture here, every day there's millions of patients entering our healthcare system, and many of them need help understanding their diagnoses, finding the right specialists, scheduling follow-up, coordinating with insurance, especially today as healthcare is getting more and more complicated with our payer groups, ACOs, regional health plans. This is where care navigators and coordinators come in. They're the human glue that holds together the patient journey. But as I described a little bit earlier in the conversation, given the massive healthcare shortage we're facing in healthcare, there just aren't enough navigators and social workers. Hospitals and clinics across the country are overburdened. Patients are falling through the cracks due to this lack of navigation. And of course, health outcomes suffer. In fact, I believe we shared a study, and we can pull that up right now, that shows over 60% of healthcare organizations struggle to fill these roles. And that's leaving around $250 billion outcome gap as researched by PwC.
Yeah, it's definitely a problem. I read a study not too long ago. I think there's $815 billion spent every year just on administrative burden within the healthcare system. So even if you could take a fraction of that out, it's a worthwhile venture for sure. There's been a lot of talk as of late about what is the role of AI in healthcare, and I'd love to get your guys' perspective on that. Is it some people think that it can truly replace humans. Other people think there's a co-pilot approach. I'd love to get your guys' thoughts on that.
Yeah, absolutely, Mike. I mean, as you know, AI has advanced a lot in the past 2 years alone, and there's a lot of talk out there of AI just getting better and better over the next coming years, and we've seen that with agents that now can use computers, can make phone calls, can do all sorts of different things that we would think of as magic 2 years ago, quite frankly. But at the end of the day, we don't see AI replacing the human entirely. We see AI much more as a co-pilot, something that can basically act like a coworker and work alongside the navigator to allow them to do their job more efficiently. At the end of the day, even if you have a super intelligent AI, humans want to talk to other humans. If you're a substance use patient coming through the ER and you need to get into rehab, you're not going to listen to an AI trying to persuade you and do motivational interviewing with you. That's just not going to happen. You need that flesh and blood human being talking to that patient, enabling them to get to the next spot. But on the flip side, you don't need a human being making phone calls to a dozen rehab clinics trying to find a bed that's open. You don't need an AI calling the patient up a bunch of times to remind them about the appointments, the rehab sessions, so on and so forth. That's where the AI comes in. So you can really see the stratification of the role where more and more of those non-empathetic, rote sort of tasks are going to get more and more automated, especially as the agents get better. And that human empathy piece is really going to require flesh and blood people to dial in, build rapport with patients, and build those connections.
So when you guys roll this out, how does it work? Do you go in and entirely replace the existing staff, and then you put the AI in with a team of humans behind it?
Absolutely. And fortunate for us, we don't need to replace much because as I was describing earlier, almost every hospital is hiring case managers and social workers.
Mm-hmm.
Yeah. So when Rely comes in, we really try to do two things. First is we understand this distribution of labor. We want our human capital to be high empathy. That means we want them there in person to see the highest risk patients and build a relationship with them. Health systems understand this as well, but where they get it wrong is they consider that to be the entire role, where if we want to scale, we just need to add more human capital. But when we think about this as Rely, it's how do we design a program that makes sure the highest risk patients have that human capital and there's AI agents working for everyone else. So that means this intricate hybrid of human and AI, and that's what we provide for health systems. We provide you local navigators that'll be there on your setting, building relationships with patients, just as your hiring of case managers would. But then we also provide this virtual model, which is really boosted by AI, where once we've built that relationship, we don't need a human to continuously monitor you, check in on you, ensure everything is going well. That's what the AI can do really well. And then if anything goes wrong there, then we can take it back. So this
Mm-hmm.
an interplay between human and AI is what we specialize in. And it is so hard, which is why we're only focused on lower wage roles right now. These navigators, coordinators, we don't even want to get into the clinical space. Right now, we can perfect this hybrid approach of humans and AI for this role. And that's why we are building Rely.
And how does that roll out? I mean, what's anytime you're bringing a new technology like this, the challenge is yes, it's getting a sale, but then how do you drive utilization and how do you drive adoption with this? I would think that the biggest challenge is trust, right? But what are the challenges that you guys have to overcome to actually have success deploying this in a hospital?
So the first critical thing that we do is we hire care navigators on our staff. So there are employees that go to the health system and work with the clinicians at the health system to implement them as a role. So if, like, for example, rather than the hospital system hiring a social worker, they hire someone from Rely, or they hire Rely to staff a social worker at their site.
Okay.
To do that, we have a team of content engineers who actually go out to the site and just shadow what the navigator is doing all day, understanding the intricacies of their regular manual workflows, where they're getting data from the EMR, what type of calls they're making, the difficulties they face in getting resources, so on and so forth. And then we had this robust no-code tooling, and a big part of that's thanks to GPT and AI, that allows our content engineering team to build out workflows within the span of a week to automate a good 50% of the tasks that that navigator would have been doing manually. That's off the bat what we do. And then over time, we continue to log and track the phone calls, the web browsers, like where they go make referrals, so on and so forth, faxes that navigators make, and we slowly automate more and more and more. So over the period of like 6 months, we end up with 90% of that role automated, and that navigator having a lot more spare capacity to talk to hundreds of more patients a month versus before.
And
I want
then
I actually want to double click on a word you used there, Mike, trust. And I think that's fundamental to everything we're doing because as you described, if somebody doesn't trust their healthcare or doesn't trust the engagement that's happening in that setting, you can call them up with an AI agent as many times, but it's not going to lead anywhere.
mm-hmm.
So when we think about trust, it's really two things. When we establish our presence with patients, we want to be an extension of the brand we work under, i.e. a John Doe hospital navigator. Rather than a Rely navigator. We want to ensure them that we are part of their physician group because that's the closest entity that patients have a relationship with in healthcare. It's their doctor. This is what a lot of payers don't understand today, where when a payer calls up a patient that's under their eligible umbrella, they still may not respond because they don't know who the payer is fundamentally. They have a stronger relationship with them. So that's the first thing we do. We always establish our programs branded off the setting they work. And then the second idea is for those highest risk patients, the ones we know will not digitally engage with us, what we want to do is we want to establish a relationship with them in their setting of care. And what that means is as soon as they're right before their discharge, we want to have a conversation with them, let them know we're their friend and we're here for them. And here's our number they can save. And from that point on, if an AI agent calls them in their number, we are significantly more likely to have them pick up because that trust is built.
Yeah. Well, so you guys have several active sites now. I'd be curious to see where have you had success rolling this out? Like when you start, do you go in and do you take over multiple departments in the hospital, or is there one area where it's like the easiest use case to get a handle on and then go from there? How have you had success with that?
Absolutely. And that's referring to a lot of our go-to-market strategy, where we spent some time really understanding where does this labor problem impact systems the most. And from all of our research, it really came down to one setting, and that was the emergency department, which is why a lot of our programs today across around 11 healthcare enterprises now, some of the largest, including groups like Kaiser Permanente, including a small regional payer in Oregon, an employer group up in Ohio. With all of these settings, we typically start in the ED. And the reason for that is very simple. As healthcare systems have been growing more and more, historically, they've always thought of their ED as the loss leader. We are losing money here, but that's fine. We just need it to keep our system running. That framework has started shifting, where a lot of health systems are realizing that my highest risk, my hardest patients, guess where they're going to show up? The emergency department. So if I have any chance at improving the worst outcomes in my population, I need to get better at coordination and navigation in the emergency department. So first and foremost, we always start there. We help emergency departments deploy a comprehensive navigation program, and that's incredibly hard because, as Prithvi was saying earlier, EDs get 30,000, 40,000 visits every year, and that's the smaller, medium-sized ones. So for that significant amount of life, the amount of human capital we'll need to navigate all of those is immense. And that's Reli's proposition to a lot of these EDs, where we can provide you a full service, comprehensive navigation program at nearly 1/4 of the cost by our ability to leverage this division of labor and AI augmentation.
Yeah, I think I saw a study Sutter did during COVID where they deployed AI agents to kind of triage um, the patients that were coming into the ER, and I think they saw 181% increase in the number of assessments that they were able to do as a result of the AI. And for hospitals, you're trying to capture new patients, right? It's difficult to get a new patient at a hospital, but they've got them coming in the ER every single day, and makes perfectly good sense. The age old question: who pays for it, and how does it? What's the economic model that you guys have been able to develop that's allowed you to commercialize the technology?
Yeah. So the critical thing that we tackle as a company is the labor budget. We're not selling to hospital IT. We're not building an IT solution for the hospital system. Instead, we are staffing a care navigator or a social worker who would otherwise have been hired by the hospital themselves. So when we go to hospital systems, we're ultimately saying, hey, rather than you hiring one care manager, care navigator, or case manager who can maybe see 20 patients, maybe 10 patients a day, hire a Rely care navigator or case manager, and we will see 5, 6x that number off the bat. And that's really where our value proposition comes in with the health system.
Have you guys seen any success with the value-based care model?
Absolutely, yes. We do work with payers, and we just recently had one in a smaller size payer, and we work with a lot of the HEDIS care gaps. AI plays a really big part in solving those. Just calling all these patients up, getting them, for example, immunization scheduled, getting postpartum visits scheduled, for example, and even with those more complicated substance use patients and those quality gaps, we still play a role there by having the AI work with our navigators as the navigators engage with patients and make sure that the navigators can see 7, 8x more patients than they otherwise would be able to.
That's great.
With these pairs, it's particularly interesting because what's happening now in the landscape is a lot of these plans are creating new quality incentives and pushing them down to providers, whether that be follow-up actions after the ED. So there's certain diagnoses that if a patient has this diagnosis, within 7 days, I need to make sure there's a follow-up appointment scheduled. There's certain substance use measures where we want to identify, initiate, and engage with patients in the ED that have substance use. So a lot of plans, their solution to high costs is pushing down new regulatory kind of quality engagements, scores that these providers have to hit. So the way providers do this is they hire for human capital. So this brings even more need to rely services, whereas plans get more entrenched in value-based care, everything is going to come down to new policies that drive outcomes. And a lot of time when these policies come about, we have to exert human labor.
Yeah. Yeah. And I've written about this on LinkedIn several times before. The AI is not a threat in healthcare because the conventional wisdom is the robots are going to take over, right? And it's going to put us all out of a job. There's no jobs to displace people from in healthcare. We don't have enough doctors. We don't have enough nurses. We don't have enough support staff, lower level wage workers that are conducting the administrative responsibilities on a daily basis. So it really it's a really unique application for the technology. So I wish you guys much success. I think that you've built an incredible technology. I want to make sure we get you guys out of here on time, but just wanted to say thanks for joining the show, and look forward to following you guys as you continue to build the company.
Fantastic, Mike. We really appreciate you having us on here, and we appreciate getting the chance to spread the word. Thank you.
Thank you, Mike.
That's it for this edition of the Bleeding Edge of Digital Health. We'll catch you on the next episode.